Good morning, everyone. So today is the second day of cognitive series. The lecture is going to be on all the standardized tests and the tools. The queries will be solved after the Agrima's lecture. I hope you'll enjoy and learn something new today. Over to you, Agrima.
Good morning, everyone. Today's lecture is on the topic standardized assessments and models or approaches used in cognitive occupational therapy. Standardized assessment. First of all, it is important for us to understand what is a standardized assessment. American Occupational Therapy Association defines a standardized test as an invariable way in which a test is to be used, as well as denoting the extent to which the results of the test may be considered to be both valid and reliable. That means for a test to be said to be standardized, its way should be invariable. That means the testing procedure is fixed. No therapist can change the testing procedure, as well as it should be valid and reliable to that particular population. It is also a standardized test is a measurement tool that is published and has been designed for a specific purpose for use with a particular population. That means it has been designed with a specific purpose and it is used for a particular population, and it has been validated and reliability has been conducted for that particular population. So now we will be going to see, seeing certain cognitive assessments that are standardized and used by occupational therapists in their daily practice. So these are the lists of certain standardized cognitive assessments that we use in our day-to-day practice. First is Lowenstein Occupational Therapy Cognitive Assessment, or LOTCA. Next is Test of Orientation for Rehab Patients, TORP. Galveston Orientation and Amnesia Test, GOAT. Test of Everyday Attention, Moss Attention Rating Scale, Trail Making Test A and B, and Rivermed Behavioral Memory Test. So I'll be discussing these tests in detail now. The first is LOTCA, that is Lowenstein Occupational Therapy Cognitive Assessment. All these scales are paid scales, so these are not available to be shown in the slides. Lowenstein Occupational Therapy Cognitive Assessment, it measures the cognitive skills and visual perception skills in patients with neurological impairments. So the original LOTCA, it contained 20 subtests in 4 areas, and it has now been modified to LOTCA 2, which contains 26 subtests in 6 areas. So the subtests, so the 6 areas are orientation, visual perception, spatial perception, motor praxis, visuomotor organization, and thinking operation. And these are the number of subtests in each category. Now, most subtests of the LOTCA are scored from 1 to 4, where 1 means patient fails to perform the task. That means patient is unable to perform the task at all. The 2 score is given when the patient is able to perform part of the task. That means the patient was able to perform less than 50% of the task. This patient is able to perform most of the task. That means patient is able to perform more than 50 to 75% of the task. And the 4th is patient demonstrates good performance of the task. That means the patient was able to complete the task with the cues or without the cues. Orientation subtest. Now most of the areas are tested and scored based on 1 to 4 range. But in the orientation subtest, the score ranges from 1 to 8. And in the 3 thinking operation subtests, that is categorization, ROC unstructured, and ROC structured, The scoring is done from 1 to 5. And the overall LOTCA 2 score ranges from 26 to 115 points. So now LOTCA has various different versions available, such as DLOTCA, that is Dynamic Lowenstein Occupational Therapy Cognitive Assessment, which is done to provide cues. It is again a dynamic form of LOTCA that we discussed yesterday. Now, LOTCA is also done for geriatric population, and it has a separate scale, LOTCA geriatrics. It is also done in children, that is LOTCA for children. And this is the only cognitive scale which could be used in aphasic patients as well. And we have specified manuals for the patients with aphasia. So this scale can be used in stroke patients with aphasia or TBI patients with aphasia. Second, for orientation, we have two standardized scales. Test of orientation for rehabilitation patients. It is generally used for inpatient rehabilitation. This scale has 46 items in 5 areas: person and personal situation, place, time, schedule, and temporal continuity. Next is Galveston Orientation and Amnesia Test, that is CODE. It is a rating scale which is used to measure disorientation and amnesia following a closed head injury. And it contains 10 questions that evaluates orientation, post-traumatic, and retrograde amnesia. Next is Test of Everyday Attention. This is again a paid scale which is used to assess different components of attention, that is sustained attention, selective attention, and divided attention. Now this scale has 8 ecologically plausible subtests, that is, this is a performance-based test where we will be assessing the performance of the client and grading the attention level. So 8 subtests are map and telephone search, elevator counting, visual elevator, lottery, telephone dual task. And the age range for this particular test is 18 to 80 years. Next is Moss Attention Rating Scale. This is a freely available scale which is available online. It is an observational rating scale for attention-related behaviors, and this has been standardized in traumatic brain injury. It is a 22-item measure which is administered manually by the clinicians. It is the scoring is on a base of 5-point Likert type scale, where 1 is definitely false, 2 is false for the most part, 3 is sometimes true, sometimes false, 4th is true for the most part, and 5th is definitely true. The score ranges from 20 to 10, the higher the attention levels. Next, A and B. Again, this scale is freely available online. It is a brief paper and pencil neuropsychological test. This test is a standard component of the Hellstead-Wrighton battery. Now, it has 2 parts, part A and part B. The part A will focus on the visual scanning and the psychomotor speed, while the part B will focus on the executive functions, mental flexibility, working memory, and attention span of the patient. Now, both parts of the trail making test consist of 25 circles, which are distributed randomly over a sheet of paper. Now, in part A, the circles are numbered from 1 to 25, and the patient has to draw lines to connect the numbers in an ascending order. That means there is a sheet where numbers 1 to 25 are spread in a random order. We will score the time of the patient, and the patient is asked to draw to connect those numbers in ascending order from 1 to 25. In part B, the circles includes both numbers 1 to 30 and letters A to L. This is a more complex form where both numbers and letters are jumbled on the sheet. Now we will ask the patient to connect one number with the one alphabet. That is, 1 will be connected to A, then A will be connected to 2, 2 will be connected to B, B will be connected to 3, and so on. So in this case, more mental flexibility and more attention span is required. Now, results for both TMT A and B are reported as the number of seconds required to complete the task. Therefore, the higher the score reveals, the greater the impairment. That means the higher the time patient or any person takes to complete the test, the more is the impairment in the executive function, in the attention span, or in the working memory. The next is RiverMed Behavioral Memory Test. This is again a paid test. It is designed to assess memory difficulties encountered by the patients with acquired brain damage. It has 11 subtests, which includes remembering names, remembering hidden belongings, remembering an appointment, picture recognition, prose recall, recalling a short route, remembering an errand, orientation, date and face recognition. So these were the standardized tests that are commonly used by occupational therapists in our day-to-day practice. Now we will be discussing the models and approaches used in cognitive occupational therapy. So these are the lists of models and approaches that we will be going through today in today's presentation. Skill task habit training, cognitive stimulation therapy, process specific training, dynamic interactional model, multi-context treatment approach, quadraphonic approach, cognitive orientation to daily occupational performance, strategy training, rehabilitative or compensatory approach, and metacognitive training. So the first one is skill task habit training. This approach is used in patients with severe cognitive impairments and patients who have impaired self-awareness. It helps the patients to develop new habits and routines and improve their specific skill or behavior. So now in this approach, we usually apply the principles of applied behavior analysis, which is that first of all, we will analyze the key behavior sequence that we need to target in our therapy. Now, first of all, we will do a detailed assessment and analyze what key behavior we need to target on. Secondly, what we will do is we will analyze the physical and social context of that behavior, that how that behavior will impact the patient's life in daily living tasks. Now, task analysis will be performed to check the target behavior and how that behavior needs to be inculcated in the patient's life. Third, next is to guide the therapist and the client. The task analysis needs to be done on the target behavior, and then we will guide the client along with the task analysis and the key behavior that we need to target. Now we will use different reinforcement techniques like chaining, prompting, and different levels of reinforcements to facilitate that behavior into the daily life of the client. So this skill task habit training is dependent on the principle of automaticity and transfer generalization. Now, what is automaticity? Automaticity is the ability to perform the task with little or no contribution from the conscious mind. For example, if someone comes and asks you to drink water, you do not have to use your mind to how to open the bottle, and you will just take the bottle and drink the water. But that is not available in the patients with cognitive impairment. They will have to think what to do, how to perform that action, and then they will do it. So we have to inculcate, repeat, and provide so much practice to the patient that they are able to inculcate that key target or key behavior into their routine life. Now, transfer generalization. The transfer generalization is that once we have trained the client in a particular key behavior, we have trained the client in a clinical setting. Now we have to generalize that behavior into his daily living activities. That means so that the client is not consciously thinking while doing that particular behavior. That is called transfer generalization. Now, how it is done? It is done through random practice order. We will give multiple repetitions to the patient of the particular task, and we will ask them to focus to go through a occupation oriented approach. That means we will not just focus on the behavior, we will try to inculcate that behavior in his daily life. Next is process specific training. So process specific training, it involves the use of cognitive exercises to remediate or improve specific cognitive systems. Now, process-specific training, it involves the use of cognitive exercises that remediates or improves the specific cognitive systems. We have yesterday seen that there are 3 basic cognitive systems that are primary cognitive capacities, higher thinking abilities, and metacognition. So in every system, there are different components. So process specific training is designed for a particular process or for a particular component. It is designed to stimulate the deficient cognitive capacity. When we perform a standardized assessment, or when we perform the assessment to screen out or to check which component is missing, we will analyze the component that is missing and we will particularly focus on single component. That is when process specific training comes into play. Now, different forms of process specific training are limb activation therapy, attention process training. So attention process training we will be discussing tomorrow when we'll discuss attention treatment. Now, attention process training is done for patients who have attention deficits. Limb activation therapy is particularly done in patients with unilateral neglect. Now, what is limb activation therapy? This therapy is based on the hypothesis that when the tasks are done through the contralesional limb in the contralesional area, in the motor circuits of the lesional brain will be activated. That means if, for example, the patient is having unilateral neglect on the right side of the brain, so I will be giving the activities to that particular patient in the left side of the body and in the left side of the space. That will activate the motor circuits on the right sides of the space. So on this basis, limb activation therapy is used for patients with unilateral neglect to improve their functional performance. Now, cognitive stimulation therapy. Cognitive stimulation therapy has come from it is a mixture of two different approaches, and it is a cross-pollination of reality orientation and reminiscence therapy. Now, reality orientation is used as a means to address confusion and disorientation and improve the cognitive function simultaneously. And it is always done in a group format for 45 minutes. While reminiscence therapy is given once a week, again in a group context, it involves discussions of the past experiences or the events like individual life reviews for the patients. Next is dynamic interaction model. Dynamic interaction model was developed by Toglia and Abreu. The fundamental assumption of this model is that cognition is the dynamic interaction between the individual, task, and environment. Now, individual may have different learning styles, different strategies, or may have different cognitive processes. While the task may have the task could have different complexities. It may be familiar to the client or maybe not, and may have different modalities that needs to be used. While the environment could be of different physical, social, and cultural contexts. So dynamic interactional model, it encourages the therapist to investigate dynamically the underlying conditions and the processing strategies that influence the performance. Yesterday, we discussed one of the component of cognitive functional performance was dynamic assessments. So that is based on the dynamic interaction model. Now, assessment, combined use of static standardized assessments along with dynamic performance-based assessments to identify the specific components and its effect on occupational performance. While we use the dynamic interaction model to assess the cognitive components, we are using both the static assessments, that is the screening assessment that we did for attention. We are checking different digit repetition tests, random letter tests. But along with that, I'm also performing a dynamic performance-based assessment such as DLOTCA, which is a dynamic assessment where we are analyzing the performance and checking the component and measuring it. Again, test of everyday attention is also a dynamic performance-based assessment. Now, what we will do for the static assessment, I have conducted 4 tests for 4 different types of attention. Digit repetition test, random letter test, troop test, reverse digit span test. And for the dynamic performance, I will do test of everyday attention. On that basis, I will have the functional performance score as well, and I will also have the measure of the static assessment that I conducted, which will help me to identify the occupational performance and the deficits effects on the performance of the client. Now, it includes estimation of client's capacity to learn, solve problems, and deal with day-to-day situations. Now, treatment. The dynamic interaction model views treatment in a reactive manner. Reactive manner here means that the client response determines that the client's response will determine the kind of therapy that will be given. And also there is no predetermined sequence of the activities. The sequence of activities are not predetermined. We will modify the activity then and there based on the client's response. If the assessment reveals that the client performance is not facilitated through repetition and practice, that means the client is not able to perform well through continuous repetition or practice, our treatment will be based on the adaptive treatment strategies. We will move towards compensatory or rehabilitative strategies. But if such input is facilitating the performance, if the repetition and the practice and the continuous random order practice is helping the client to facilitate the performance, he or she is able to improve the performance, we will go towards remediation techniques. Now, multi-context treatment approach. Multi-context treatment approach is one such approach which is purely based on the dynamic interaction model. It addresses the issues of generalization. Now, it views learning as an interaction between internal person and external activity demands and context variables. So, what are the internal and the external variables here? Internal variables includes characteristics of the person or an individual, where the characteristics of the learner are included, like the previous experiences of the learner, what is the previous knowledge, what are the values of that person, personality, coping skills, how that person handles the emotions. Also the structural capacities, that is inherent fixed abilities or the primary cognitive capacities. As we already know that for higher thinking abilities and metacognitive processes to be working, we should have intact primary cognitive capacities. So that is important. Self-awareness or knowledge and beliefs of one's abilities is important, and the performance processing strategies, how the patient is able to process the what he is performing or what she is performing, and how effective and efficient those exercises are, that needs to be analyzed by the individual. In external variables, we have activity demands, like what are the number of items required, what are the number of steps, how the things needs to be arranged, how familiar the activity is to the individual, and apart from that, contextual factors, in what context the activity is being performed, the physical context, the social context, and the cultural context. Now the problems in the processing information and learning are understood by analyzing the dynamic interaction between the person, activity, and context. We are analyzing the problems in the cognitive dimensions by analyzing interaction between person, activity, and context. Now, when the activity demands or the context will change, again, the type of the strategy that we'll be using as a treatment will change. Intervention focuses on increasing the efficiency and effectiveness of the processing strategies and self-monitoring techniques within purposeful and occupation-based activities. That means we will be providing the activity or the strategy to the client based on his or her own occupation and purpose. Activity parameters and context are systematically varied, while the same strategies and self-monitoring techniques are practiced across different situations to facilitate learning and generalization. Again, we will systematically vary the different activity parameters and the context of that particular task that needs to be done, but our self-monitoring techniques and our treatment strategies would remain same, and we will apply those techniques into different situations to facilitate learning and generalization. Now, components of multi-context treatment approach, how we will apply this multi-context treatment approach clinically. So the first part is specifying a processing strategy for transfer. Now, what could be the processing strategy? So like for example, if I want to teach someone sorting and categorization, how will I proceed using multi-context treatment approach? The first part is specifying a processing strategy for transfer. The strategies could be internal strategies or external strategies. Internal strategies means that we are using ourselves. We are using self-motivation, self-cues, self-reminders, self-questioning, and mental imagery to provide cues to ourselves to perform the task. While the external strategies include use of aids or interactions with the others or interaction with the environment. For example, we are using a checklist, we are using our caregiver, we are using a memory notebook to implement that strategy for transfer. Now, second step will be analyzing the activity and establishing a criteria for transfer. Now, we have to analyze the activity that we need to teach the patient, and we have to establish how we will transfer that into the daily routine of the client. So there are 4 levels of transfer: near transfer, intermediate transfer, far transfer, and very far transfer. Now, near transfer means that we will be giving very similar activity to the patient. That is the alternate form of the same task. Intermediate transfer means we will be changing 3 to 6 parameters of that particular activity and giving somewhat similar tasks so that the patient starts generalizing that strategy into his routine life. Next is far or different transfer. That means the concept will remain same, but changed. We have changed a lot of activity parameters now. And very far transfer means that we have transferred that particular activity to the daily routine of the client. So I'll give you one example. For example, I have taken that we have to teach the client sorting and categorization in the kitchen area. Like which of the boxes of the spices are empty and which are full, and how to fill those boxes. So the first is our near transfer. That means first we have to teach the patient cancellation of the particular thing so that he or she is able to focus his or her attention on a particular task and perform it. So now I will start this activity through a letter cancellation task. I will give a sheet of letters and I will tell the patient to cancel the letters. This is the first step. That is the near transfer. We are giving the very basic and simple activity in the clinical setup to ask the patient to fulfill all the demands that he or she is having. Now, after the letter cancellation, we move on to intermediate transfer. That is, we will give a different activity. The 3 to 6 parameters are changed. For example, I have put a lot of buttons of different colors, and I will ask the patient to choose all the blue ones. That is intermediate transfer. Now I have transferred it to daily living objects. Now far transfer. In the far transfer, now I will keep the spices boxes. And in those spices boxes, I'll keep 2 or 3 boxes empty. And I'll ask the patient to select the empty boxes. That way, the patient is able to learn the sorting in a transferable manner and in a easier manner. And last step, very far, that means we will be shifting the context of the patient. That is, now from a clinical setup, we will be going to a kitchen setup and we will ask the patient to repeat the activities. So that is establishing the criteria for transfer, how we will be generalizing a particular activity into the client's life. Third step is practice application of the strategy in multiple activities and contexts. That I already explained how we will practice that particular strategy in multiple activities and different contexts. Now, train awareness or metacognitive training. Metacognitive training I will be discussing in the future slides. We will be creating self-awareness techniques for the patients and the self-monitoring techniques through which patient can monitor his or her own performance. And the last is consider learner characteristics. We have to consider what are the strengths and weaknesses of the learner, how the learner is able to learn fast, what are the ways in which he or she is able to perform better. So this was multi-context treatment approach. Now we are moving on to rehabilitative or compensatory approach. Rehabilitative or compensatory approach, it emphasizes on teaching the client to be independent, using adaptive equipments, new methods to accomplish functional tasks, and adapting the environment. This approach is often chosen when further recovery or remediation of the impairment is not expected. Next is strategy training. Strategy training, it involves different cognitive strategies where an array of tactics are intentionally employed to optimize the performance despite a cognitive limitation. In the strategy training, we are using 3 phases: acquisition, application, and adaptation. While in acquisition, we are drill and practice exercises where we are teaching the patient we are teaching the patient how to use the compensation. We are making them learn the compensatory strategy. In the application, now we will be providing simulatory activities. That means now we have taught the patient compensation. Now we will simulate that activity for the patient so that he or she is able to practice it and learn it, and then he or she will be able to adapt to that particular compensation in his daily life. So now we have applied that particular compensation. Now we are going towards adaptation. That means adapting to it, adapting that particular compensation in the client's regular life and according to the client's demands and personal preferences. So for example, in sometimes in patients who have severe memory loss or severe cognitive impairments, we provide alarms and we provide memory notebooks. These are compensations that are for first stage is acquisition, where I will drill and practice, where I will constantly provide lot of cues and feedback to the client so that he or she understands how to use that particular technique. Like for example, if you are using alarms, we will train the client alarms in every activity he or she performs in the clinic. Then we will apply it in then we will simulate it. Like for example, the client forgets to eat his food on time. We will stimulate the eating or the feeding activity in the clinic along with the alarm so that he understands how to use that alarm during his feeding time, and we will apply it in a simulated activity. The last is adapting that activity at his home environment or at his work environment. Now we will adapt that activity. We will provide different situations through which we will ask the client to adapt that alarm system into his routine life. Strategy training involves memory strategies. There are 2 types of memory strategies: passive memory strategy users and active initiators. So passive memory strategy users are the ones who are using the passive resources. They're not using themselves as the memory strategies. They're using others or the environments or systems that help them to assist into memory. That is a caregiver setup. Maybe the caregiver is providing cues and caregiver is giving signs or signals to perform a particular activity. Or we can use or maintain an external memory system such as reminders or calendars, different form of external systems or compensations. Next is active initiators. Active initiators means that the person themselves are aware of the problem and they're learning to recognize situations when they have to use the memory strategy. Active initiators, in case of active initiators, the patient is aware that he or she might forget that particular task, and now they are trying to learn the situations where they have this problem and they will use a particular memory strategy to solve that problem. Now, internal memory strategies and external memory strategies. In internal memory strategies, we have association techniques such as visual memory, where we associate the current thought process with a previous thought or experience, and we imagine the particular situation and we try to solve the problem. Next is organizational techniques, that is mnemonics, creating short forms, creating mnemonics to remember the things that are crucial for us to perform a particular task. Now, external memory strategies involves reminders, alarms, or low-tech memory aids such as planners and calendars. Next is metacognitive training. Metacognitive training involves teaching the client how to identify a problem and develop their own methods to overcome these problems. In the metacognitive training, we are teaching the client to self-identify the problem. They will themselves identify the problem. They will themselves develop their own method of solving that particular problem. So how this metacognitive training could be done? The components are, the first step is to identify the problem and select the activities to improve the daily function. The first step to any treatment is to identify what the problem is, where the problem is lying. That means in metacognitive training, we will first train the patient to identify the problem and select the activities of daily life that are having a particular problem. Second is we have to identify the nature of dysfunction. What is the nature of executive dysfunction that the patient is having? Third is to design self-instructional procedure. Now we will assist the client in designing a self-instructional procedure that is again client-centered and occupation-centered. That means the client will be analyzing his or her activity and his or her problem, and based on his or her own routine, they will be designing a self-instructional method, that this is how I will instruct myself to perform a particular task. Now we will model doing the task using self-instructional procedure. Once the self-instructional procedure has been made, now we will model doing that task. Like if I have to give the presentation today and I was nervous. So I have this self-motivation method for myself. I will apply that to this particular task to calm myself down. Similarly, in the patients, when the patient has developed a self-instructional procedure, we will model that particular procedure into the task that is problematic, that the problem we have identified. Now practice the task using self-instructions verbally. Now, once the self-instructional procedure and the tasks are aligned, we will ask the patient to practice it again and again and speak the self-instructions loudly and verbally, so that he or she gets more stimulated each time he or she performs the task. Now we will reduce the prompts slowly, and we will provide cue cards whenever the client will get stuck. The next stage is, after verbal repetition, we come to cue cards. Now we will be using cue cards only at the stages where the client is getting stuck. Next step is practice, practice, and practice. Now we will ask the client to practice this self-instructional procedure while performing the task, but he or she only has to whisper it to himself or herself. It need not to be given in a form of cues. Now slowly we will fade the prompts to inner speech. Now the client will only speak to himself inside his or her own mind. That means self-awareness. Now lastly, we will generalize this self-instruction into the task or the daily life of the client. Next is cognitive orientation to daily occupational performance. This is again a client-centered, performance-based and problem-solving approach. It enables skill acquisition through a process of strategy use and guided discovery based on learning theories and skill acquisition. In this approach, again, we are focusing on the occupational performance of the client and help them to solve the problem. So we are enabling skill acquisition through using different strategies. The focus is to assist client in identifying, developing, and using cognitive strategies to perform daily activities. Our focus is on identifying what are the areas where the cognitive strategies needs to be identified, and then we will develop strategies accordingly. Now, implementation process involves four key processes. Skill acquisition. First of all, again, we have to identify the skill that we need to acquire. Now we have to identify cognitive strategy use, how we will use our different cognitive strategies to apply to that particular skill. Now we will generalize, again we will practice it to generalize it into the daily performance, and transfer of learning, to transfer that learning, clinical learning, into the routine life of the patient. The key features of this approach are that it is a client-centered, occupation-based approach. The goals are always based on the individual. That it has dynamic performance analysis. It dynamically analyzes the performance of the client and focus on the individual. Cognitive strategy use. It uses different cognitive strategies. Guided discovery. There, the therapist will be guiding the client throughout the process, while he or she is identifying where to stop and when to remediate. enabling principles. It enables the client to explore more on their own. Parent or caregiver support, it helps in providing caregiver and parental support and intervention format. Thank you. Any questions?
Okay. It was a very nice presentation, Rama. I think we can take question answers now. If you are having any question answers, kindly write it on the chat box. Can you repeat about the activation therapy? Okay. Okay.
Limb activation therapy is used for patients with unilateral neglect. In unilateral neglect, the patient is neglecting half of the body. So suppose example, the patient is having unilateral neglect on the right side of the brain. That is the lesion area is right side of the brain. For using limb activation therapy, we will be providing the activities on the left side of the body. That means we will ask the patient to perform the task to the left limb, left upper limb or left lower limb, and we will be giving that task only in the left hemisphere of the space. That means the task will be performed and the limb will be used only on the left side of the body, which will help us to activate the motor circuits on the right side of the brain. And this will help to reduce the neglect features. I hope it is clear now.
You can open the audio also, no? For the students if they want to ask the questions. You are having now the this right to enable yourself as unmute. So you, if you want to have any query and you want to talk to Dr. Agrima, you can. Okay, we can take another question. This is from Shiksha. How is skill habit training different from task oriented approach? Is it on the basis of amount of practice?
In a task oriented approach, we are using a particular task functionally to reach out to the to our goal. But in the skill habit training, it is not important to use a particular task. We have to inhabit us. We have to train the client in a particular habit. It need not to be focused on a particular task.
Okay, there is another question. In case of generalization of task, what I have noticed that the patient performs the task well in stimulated environment, but in real life scenario, they have some problems to carry out those tasks. So which approach will be more useful in the case? This is asked by Snehil.
In the generalization case, I think the practical application is more useful using multi-context treatment approach, because it is working on the simulated task as well and how to incorporate that simulated task into the routine life. So using multi-context treatment approach, you are able to inculcate that activity into different situations and help the client reach out to the daily performance level as well.
I can read some comments about you also. It was useful and very explanatory lecture. Thank you. It was so. It was a good and knowledgeable lecture. Can you please suggest some reference books? Sandhya is asking if you are having any reference books for that.
We can share the references on the group itself.
Yeah, we can do so. Any other questions? You can unmute yourself and also you can ask for, if you want to talk to Agrima about anything, yeah, you want to discuss anything with Agrima, you can unmute yourself. Okay, Snehil, what are the indications and contraindication of these approaches, and what are the challenges the OTIS can expect during the cognitive rehab program?
For the indications and contraindications of the approaches, I think indications are quite clear when to use which approach. That is the analysis of the therapist per se. And for the challenges for the therapist during the cognitive rehab program is that you have to be extremely patient with the cognitive rehab patients because they are extremely challenging. They will lose patience. You have to repeat yourself again and again. Sometimes it will become very frustrating for the therapist as well to provide treatment, but you have to calm yourself down. You have to maintain your ethics and provide the treatment.
That's so true. Okay. I don't think so we can share the PPT later, but you are having all the lectures recorded into YouTube. You can go to the link and you can see the videos if you want to see it later. Dr. Jasmine is asking how we can transfer the training for memory from hints to get direct answers.
Sorry, your question is not clear.
What do you want to say, Jasmine? It is actually not clear. Any other participants who can talk or who want to express their views about the PPTs or anything? I think we are running out of the time. Okay. If you are having any other queries, you can directly message to the group. Agrima will consider all the messages. What happened? Okay. So I was going to say that all the queries will be considered by Agrima and she can message you later. And we are going to shut the PPT now. For today's lecture, we are over. Is there anything? Yeah, I'll send the feedback form in the group. The participants who are present in the lecture will get the certificate and will be considered for giving the certificate. Other than those, we will not consider and they will not get the certificate. So kindly attend the meetings. Okay, I think this is it for today. We'll meet again by tomorrow at the same time. I'll share the link prior 30 minutes to the meeting. Thank you, Akrama. Okay.